Good afternoon, everyone. My name is Monique Mrazek, and I am a senior health specialist focused on health tech in the disruptive technologies team at IFC. I'm really pleased to be with you this afternoon and be your moderator for this panel on point-of-care diagnostics. During this panel, we'll have the opportunity to learn about innovative technologies that are bringing healthcare diagnostics to the point of patient care, including into remote settings. The diagnostic technologies we will cover include infectious diseases, breast, cardiovascular, and eye disease. Without further delay, I'd like to introduce the panelists for this session. First, let me introduce Dr. Charit Boraj. He's the founder and CEO of TriCog. TriCog is an Indian-based company with an international footprint, leveraging AI to provide accurate and instant diagnosis of cardiac incidents. Next, we have Joaquin Delaventhal. He's the Chief Responsibility Officer at ISTalk. ISTalk is a Finnish company integrating diagnostics, machine learning, mobile technology, cloud computing into a single platform. Next, I'd like to welcome Mihir Shah, who's the CEO of UE Life Sciences. UE Life Sciences is working to bring early breast cancer detection to emerging markets with a quick, painless, and radiation-free handheld screening device. Next, I'd like to welcome Jose Luis Nuno Ayala. He is the CEO and co-founder of Unima. Unima is a Mexican-based company leveraging biotechnology and mobile technologies to provide low-cost, rapid, and real-time disease diagnostics. And finally, let me welcome SK Shimizu, Dr. SK Shimizu, who is the co-founder and CEO of We Inc., or Wink. Wink has developed the Smart Eye Camera, a low-cost portable device manufactured by 3D printing and attaches to a smartphone, enabling images to be transmitted to ophthalmologists remotely. So thank you all for taking time to be part of this panel today. We'll first start with our lightning demo videos of each of the panel companies, and then move to a Q&A session. If our tech team could please start the demo videos.
Every day, our world is getting more and more crowded, and it's getting warmer too. This combination creates perfect breeding grounds for infectious diseases such as malaria, hepatitis, Ebola, Zika, and dengue. Today, point-of-care testing and diagnosis are time-consuming and costly. They're also vulnerable to human errors, and the ability to react fast to restrain epidemics is poor. Luckily, it doesn't have to be like that, and it won't. iStock, immediate diagnostics and fast care. iStock is all you need for faster and more reliable diagnostics, analytics, and care for any infectious disease. It turns a smartphone into a versatile and easy-to-use medical device for point-of-care testing. It's already used in Asia, America, Scandinavia, Middle East, and Africa. The patented iStock is globally authorized. With iStock, a patient can start medical treatment almost immediately after the diagnosis. This is how it works. A nurse takes a rapid test. Then she opens the iStock application on a smartphone and scans the test with the iScan camera. The result is sent automatically and safely via the iStock cloud server to a consulting physician for diagnosis. The results are stored in an electronic health record, and treatment guidance with an e-prescription is sent back to the nurse in a second. The patient can get medical treatment right away, and he'll get better much faster than before. The iStock mobile health solution offers remarkable benefits not only for individuals, but also for the healthcare providers, society, authorities, and non-governmental organizations. In the prevention of epidemics, iStock is an invaluable tool. It shows on a map in real time if there's a risk of an epidemic in a certain area, for example. With a faster reaction to an epidemic, iStock simply means save lives, save time, and saved costs too.
So my name is S.K. Shimizu, Dr. S.K. Shimizu. I'm the CEO of our company called We Inc. So We Inc. is the startup of the Keio University School of Medicine. Right now, 36 million patients are suffering from blindness worldwide, and the numbers are increasing these days. Our aim is to overcome 50% of world blindness using our device. So we want to solve these kind of problems. That's why we create this product. Our product is called the Smart Eye Camera. It is the attachment of the smartphone, which converts the smartphone to the device called a slit lamp microscope. It's extremely simple. Just plug in this attachment and use the apps to record the eye, and that's it. This function as a slit lamp microscope. You can take the photos, you can take the images. There's a thin slit light using the device, and you can take a selfie with this device as well. The main function of the Smart Eye Camera, we use the light source of the smartphone and the camera function of the smartphone. Therefore, we don't need any extra batteries. We don't need any other tools to diagnose. And this is the best point. Because if you charge your phone, you don't need to plug this to the any places. You can use it everywhere. So this product is not just only tested in Japan. We tested this device in Vietnam, Mongolia, Malawi, Zambia, worldwide. We use this device to screen the patient who does not have any ophthalmologic examination in the past and diagnosed the new eye disease. So smart eye camera has an equal function to diagnose the anterior segment eye disease, for example, cataract, dry eye disease, allergic conjunctivitis, corneal opacity. So we want to make the new examination style of the ophthalmology using the smart eye camera. Because this is a phone, we can do the telemedicine. For example, in Africa, in Japan, we can make the AI to make an auto-diagnosing system. I believe the main problem is that there is the Department of Ophthalmology is not common in worldwide. By spreading this device worldwide, we can give them the eyes of the ophthalmologist that can prevent blindness and visual impairment in the future.
Six hours after a heart attack, there is an 80% possibility that the patient doesn't survive.
And that's why we built TriCog. From identifying patients with heart attacks to coordinating their care at hospitals, TriCog ensures timely treatment and intervention. All this within 60 minutes, what we call the golden hour. The more we exceed the golden hour, the lesser the chances of survival.
TriCog is an ECG solution that provides an accurate report in less than 5 minutes. The moment a doctor takes a patient's ECG, the information is sent to our centrally located hub, where a qualified expert is available 24/7. So every time an ECG is performed with TriCog's cloud-connected ECG device, a TriCog specialist interprets it and sends the report through an SMS as well as a message on the mobile app. Diagnosis also suggests if the patient has to be referred to a specialist cardiology center located nearby, in case the clinic doesn't have in-house facilities to manage the critical cardiac condition. This facilitates transferring the patient within the 60 golden minutes.
Our team has experts in medicine, hardware, software, and analytics. People from around the globe with decades of experience. We've all come together to create TriCog.
Instant diagnosis helps increase the chances of a safe recovery by 6 times. It reduces the time between diagnoses to treatment by half. Since 2015, TriCog has been helping thousands of patients in hundreds of clinics, and this is just the beginning.
TechEmerge system and their team have helped us serve many patients which otherwise may not have been able to help with the same efficiency.
We live in a time where technology has changed every aspect of our lives. TriCog's innovative technology provides every patient with an accurate, immediate diagnosis for something as critical as a heart attack. The TriCog solution aims at changing the 80% chance that a heart attack will take your life to an 80% chance that you will survive. It is about time that we stop taking our hearts for granted.
Well, thank you to all of you for sharing these excellent demos, some really incredible technologies. And it's really exciting that you're part of the TechEmerge program. So I'd like to move into the Q&A portion of our panel. We're going to have probably around 40 minutes for Q&A. I'd really be grateful if you can keep your answers to 2 to 3 minutes max so we can get through more questions. So I'd like to open up with our first question to Joaquin and to Jose Luis. So both ISTOC and UNIMA offer point-of-care diagnostics that are really an alternative to conventional lab diagnostics. Can you describe for our audience some of the key benefits of in vitro point-of-care diagnostics, as well as some of the limitations these solutions might have? So Joaquin, I'd like to start with you. You could please respond to the question.
Sure. Maybe I can start by saying where we come from in developing our technology. And that is that I think there's generally 3 or actually 4 big problems with diagnostics and healthcare provision in areas where you have a thin coverage of medical professionals, access to diagnostic technology, laboratories. So the point of care is extremely important. And those are that access, first of all, is a big challenge. Then affordability is a big challenge, and quality of the diagnosis, if there is any, is a big challenge. And then that's on the individual level, but also we're missing sort of a digitalization, a connectivity across the system. Those are 4 issues that we try to address, and I think that point of care diagnostics can deliver much better than laboratory-bound stationary approaches.
Thank you. Jose Luis, does what Joaquin said resonate with you, or do you have a different perspective?
I think Joaquin made a very good overview of the problems of diagnostics in emerging markets. I might add also, for example, the problem of reporting results to authorities, for example, in the case of infectious diseases. Normally, this will take a lot of time because it's being done using, well, very old technologies. So point of care diagnostics can solve some of these problems. One of, I think, the most important advantages of this kind of technology for emerging market will be, of course, the possibility of using simple and most robust technologies where it's more needed. So, for example, if you have a technology to do detect diseases, which is actually quite good, for example, let's say an ELISA test, there's already technology that can allow you to do, for example, immune tests directly in remote areas and solving most of these problems. Technologies that can be used by people with limited training, that can be used even in places where there is no electricity. In this case, for example, with the possibility even to be reporting on real time using remote systems like a smartphone and applications and software developed to do this. So these kind of technologies actually, I think, will make a big change on the way that diagnostics are being done in these emerging markets.
Excellent. Well, thank you so much. Manir, I'd like to turn to you. UE Life Sciences is really offering a unique solution for early stage breast cancer screening, which, as your demo showed, is really a high unmet burden in a lot of emerging markets. Can you describe for us where the eye breast exam fits in relative to more traditional diagnostics like mammogram or breast ultrasound, if these are even available, and the decision process a health provider might consider when deciding to purchase this type of device. Mahir?
Sorry, I was on mute. Monique, the challenge really in the emerging markets, developing countries, is a layered one. We don't have access to the expertise and the resources, radiological. We don't have access to machinery, which need wall power, maintenance, and what have you. And so the issue is one of last mile access, as some of the, as Hakeem talked about. Access to affordable, easy to use, accurate point of care diagnostics, because that's what's required in the communities across the developing world. And what iBreast Exam, this device, is able to do is pair with a mobile phone and enable a frontline health worker to be able to offer that breast exam for which you don't have the expertise-based manpower or specialized skilled manpower or the equipment. So on one end, we equip and enable frontline health worker to become expert breast examination delivery mechanism. But that very same frontline health worker also then with our mobile app acts as an access to treatment. So we are able to do both, not just triaging for early detection of the breast health, but also connect that with treatment, which is equally important. And so that's the value that we bring.
Great. No, thank you so much. I think that the point you made about sort of enabling the remote healthcare work, I think, is really relevant. And Dr. Chard, I think that's also relevant in the model that you have with TriCog. With TriCog, you heavily leverage data and analytics to make diagnostic recommendations. Can you describe, how you use AI as part of the TriCog solution? Any adaptation that you'd require in taking this solution into the African context?
Thank you very much, Monique. And I will start off by giving a quick example of how TriCog was used quite recently in a small town called where a hospital, Nanyuki Hospital, a community hospital, 3 hours from Nairobi. A person goes there with chest pain, uses the TriCog service, administered by a nurse. The data comes to the TriCog center, diagnosed by AI, verified by a cardiologist at Aga Khan Hospital, and the diagnosis of a heart attack being done within 5 minutes. The patient administered a drug called thrombolytic, and the next day shifted for further treatment. And to make sure that the entire loop is complete, and from the point of diagnosis to the point of initiation of treatment, what we do is, of course, enable frontline healthcare workers with the ability to diagnose heart disease. And the key component in the next step is, of course, the AI that makes sure the diagnosis is not only accurate, but is done within a very short time frame, and the entire technology for care coordination. So with each of these steps, I think it is pivotal that technology is used to enable delivery of not only diagnosis, but delivery of healthcare in all parts of the world, especially in Africa.
Great. Thank you, Dr. Charit. Dr. Shimizu, We Inc. has developed a really interesting diagnostic solution that leverages the cell phone to deliver eye diagnosis. Can you explain the significance of how this solution is really going to bring increased access to eye diagnostics, particularly in low resource and remote settings?
Yeah, thanks, Monique. So I think the key, there's two keys. Number one is the simplicity of the device, and number two is the IoT device. So for eye diagnosis, well, I'm an ophthalmologist, so let me just give you how the logic is. So we're gonna expose the light to the patient's eye and see the reflection of the images. And the smartphone has that function, the light source and the camera. but the smartphone does not design to record the eye to make a diagnose. So we made the device with this attachment. So this is very simple, and you can just press it, and you can even take a selfie. That's simple logic to expand the to take the diagnostic worldwide. And as it's smartphone, you can record it, send it, and the most interesting part is that the ophthalmologic diagnosis is 100% imaging diagnosis. So if we can gather as much data as possible, we can create the diagnostic AI, and that makes much more valuable for especially the low income world themselves.
Thank you. I think with all of you, one thing you all touched on was sort of enabling capacity in remote settings. So one question I'd have for all of you is, when you think about, or if I was a provider and looking to onboard your solution, what should I expect in terms of that onboarding process, integrating with my existing systems, if I have them, training of my staff? Is it quite involved in terms of the training? So I'm not sure who would like to start. I don't know, maybe we can start with Joaquin or Jose Luis.
Yes, I think some of the things that our solutions seem to have in common is that there's not a lot of onboarding. I mean, if I can speak for our solution, is that all you need to do is have access to a smartphone, which is luckily getting easier and easier everywhere, and you download an application. There's a tutorial in the application, and the good thing is that the basis for our diagnostics is a very simple, ubiquitous, very old technology, the lateral flow test, that you can use for virtually any kind of diagnosis, and that is recommended by the World Health Organizations in their essential diagnostics list for a wide spectrum of diagnoses. So a simple urine sample, blood sample, serum sample is enough to actually perform the test, and then holding the phone over the test will already give you the diagnosis. And I can see there's a question in the chat asking, okay, how much specialist involvement is needed? Essentially, there is not much specialist involvement needed. It's an option that you can create. I mean, our technology puts a big emphasis on working when there's no connectivity at all. So you don't even have to establish an internet connection where you're doing the diagnosis, because it's all done in the application through the algorithm. So you have the result confirmed, and you're eliminating human error in the process. And then you can consult a consultant, a specialist anywhere in the world through the cloud, if you want to.
Great, thank you. And Dr. Shimizu, you also use a phone as part of your application. Is it similar onboarding process?
Yes, well, it's pretty simple, and for eye diagnosis, it's the same thing that I said, but you just have to expose a light to the eye and see that record the reflection. So I think the key is what kind of image that ophthalmologists want, and as we can show the references images, it's really easy to take. And I have one interesting story. So when last year when we tested this device in Malawi, there was that's called a paramedical, which is like a clinical officer in Kenya, and they used to use this microscope, the existing microscope, and Mr. Nakama went there, and he taught them about the smart eye camera for only 2 minutes, and they know how to use it. The interesting thing is that iPhone is not popular in Malawi, so he has to teach how to use the iPhone instead of how to use the smart eye camera. So I think if you know how to use, or if you can teach them what kind of image that we want in the ophthalmology department, it will be super easy and super easy to use the app as well.
And do you need like a certain amount of like Wi-Fi capacity or wireless capacity? How important is that, or how much is that a limitation?
Yes, so if you want to do the telemedicine, you should be connected to the internet. That could be one limitation. But we are now creating the auto-diagnostic AI, and it's the same thing. We're just going to contain the algorithm inside the app, and if that happens, we don't need to connect to the internet for the auto-diagnose.
Dr. Sherritt, what in the case of TriCog, what does that onboarding process look like?
So I think it's a very important question, especially when we're dealing with a low resource setting such as Africa. And what TriCog has done or focused on is a few very important basic principles. And the first and foremost is that any technology that you introduce should not change the workflow of the healthcare provider. The minute you introduce a change in workflow, that's when training becomes difficult, usage and adoption goes down tremendously. So we spent tremendous amount of time to ensure that there's no workflow change. And what we have done is work alongside with our local partners in every country to ensure that we do capacity building. In Africa, for instance, we've trained close to 500 healthcare workers to take an ECG, and that takes about 15 minutes of training. But ensuring that we build on capacity, providing another source of livelihood, upskilling existing healthcare workers is a very, very important mission for TriCog. The third important aspect is that you have to make sure that anything you do deals with the existing infrastructure. And for instance, TriCog has been designed to work with a 2G setting entirely automatically. So the healthcare worker who is administering or taking an ECG, the entire process of connection to the internet, uploading the data is completely transparent, with no user interface whatsoever. So, and that is how we've designed, considering a low resource setting, especially in the context of Africa.
Great, thank you. And I guess sort of maybe taking this to Mahir, how do you, maybe talk through us your onboarding process, and also maybe if you also can take into consideration how you consider, maintenance or updates in the context of your solution in Africa.
Sure. So for us, it's been a learning curve over some 400,000 breast exams across 12 countries over the last 3.5, 4 years. And we've come to learn that training is a very, very critical aspect of delivering success out of our technology. And we've made some extensive, we've taken extensive steps to ensure that last mile efficacy does not take a hit because of lack of training. Onboarding has now come down to us shipping the device over to the provider and doing an hour worth of online Zoom training. There is some video material and training materials that we share ahead of time. And once the test is, the training is complete, they go through a certification process of performing 20 breast exams. And those exams come back to us. We validate them. We look at the completeness and the profile with which they've done the exam. If they can provide us with comparative tests, whether it's a clinical exam or a mammogram, that's also factored into the certification. And then they're off to the races. So there is a two-step process. And we've done a lot in terms of making it intuitive so that training is, within an hour or so. I think there was a second part to your question, Monique, for me.
Yeah, about the sort of, if we think about sort of maintenance or updates that might be required to the device.
Sure. So we are a two-part device, both hardware and software. A software is a mobile app, and that part of it is very easy to upkeep and maintain because it's an automatic update like any other app that we use. And so what we've done is most of the brains of the data coming from the device, from the scanner, is all into the app. And so we do have revision of the hardware that happens much more, I guess, less frequently. We recently came up with a Generation 2 sensor technology, but that was after putting out some 500 devices in the market. So hardware is much harder to update. And we have basically a maintenance-free approach to the hardware where you simply replace the device. There is no maintenance or repair required. And then the software is through the App Store.
Great, that makes sense. Jose Luis, what about in your case with your solution? How is the onboarding process? And how do you also ensure sort of maybe the quality assurance of the solution once it's on the ground and in the hands of healthcare workers?
Okay, for us, the onboarding process is quite important because our goal is, for example, for healthcare workers to receive our product and be able to start using by themselves without any interaction with us. So we develop the complete process of onboarding, focusing on the main limitations that low resource settings have and the human factors part of how to actually use our technology on the field. So when the user actually opens a box for the first time, you'll have everything you need to start working on this. So you start, for example, by by downloading the application from the App Store or any other way. So you got it on your smartphone, and then the application by itself has a series of steps to actually start working with the application and start actually by testing that your smartphone is capable of doing the process. So in the box, you will find, for example, a couple of cards, which are like training for your smartphone of the test that you're going to run. So you will see images of our test. You take a photograph of each one of these images on the cards before being authorized by our servers to actually use the application to do diagnostics. Once you prove that your smartphone is capable of doing the test and is approved by the server, the next step is doing the onboarding of, let's say, your relationship to certain kind of organizations, etc., for data collection. Once you go through that process, you are ready to start testing. Inside the box, you will find completely visual instructions on how to run that test. So it will give you, for example, step-by-step and recommendations for running a blood test, for example. In this case, maybe the only thing that the user will need to know is how to prick a finger, and that's it. And even, for example, for our new COVID test is completely saliva-based, so you don't even need to do anything related to blood draw from the patient. So everything that you need is on the box. And after doing some testing of human design, we know, for example, that one person should need less than 30 minutes to actually get the complete onboarding and start using the test. We have seen, for example, from remote interaction with users, that one user will take no more than 2 tries to actually run the test correctly by himself, with no interaction with us, no videos, no whatever, only the things that are in the box. And then for being able to track the quality of the process, what we do is we analyze the photographs that we are getting, for example, in a statistical way from users. So we can see, for example, if they are making some mistakes, for example, in execution, etc. So we can do non-interactive recommendations. And on the other side, the application actually needs, for example, for you to be like restating that your smartphone works perfectly or camera works perfectly. So each number of days, each number of weeks, we will be asked to do again, for example, the reading process of the cards to know that your camera is working well. So that way we are like trying to be very, very careful about the quality of the process and the quality of the smartphone for doing the process. And that way is how we know that they are executing correctly and the results that I'm getting are correct.
And that engagement's all through the cell phone, that communication?
Yes, everything is through smartphone. Of course, we are open to do on-site training, etc. But the thing is, for scaling up, you need actually to be able to do this without any kind of interaction to actually reach millions of users in the world.
And if they have problems, they also can reach you through the cell phone?
Yeah, there's a way of getting in contact with us through the app.
And Joaquin, what about in the case of iStock? You know, is that similar in terms of assuring the quality assurance? Is that done through the phone? And also, if you have additional tests that you're going to be providing, is that also done sort of through the phone in terms of the training and onboarding?
Yeah, first of all, we're completely manufacturer, brand, and test agnostic. So any lateral flow test can be analyzed through our platform. Before we onboard any particular test, we run it through a trusted laboratory to make sure that the test itself is good. We are starting to produce our own tests and are actually going to offer a manufacturing in a box concept where you have a fully automated production line to produce your own lateral flow tests for national or regional use. But when we use third-party tests, they run through a laboratory, so we ensure the quality of the test. then our solution is US FDA and CE certified. So the actual process of confirming the result and reading it out is more precise than the human eye. So we have a higher correctness than the person administering the test itself. So we're improving on this technology of the lateral flow test, and it's all done by the app. So there's no need for a certain qualification or training. We do, however, offer an online certification with the university in Finland where you can log in and learn about infectious diseases, telemedicine, and the actual process of using the application, where you find that necessary, and in some places it's actually required that some training is taking place, and you can do that completely online with us.
And what about new applications? Or if there's new diagnostic tests, that's all done through a cloud, sending that to the iPhone. How do you sort of manage that?
Yeah, new tests, when we integrate them, we just receive a couple of physical samples. We integrate them into the algorithm to make sure that the app is completely adjusted to that specific test, the line intensity to do a cutoff between positive and negative results, to do semi-quantitative analysis on the test. For example, we have an application that allows you to take a regular pregnancy ovulation test and actually estimate the hormone levels. So you can make not just a binary result, you actually can tell how long somebody has been pregnant or how close they are to the ovulation. So there's more to the analysis than simply the binary result of the line being there or not. So that's an added value that we bring as well.
Okay. So Dr. Shimizu, in the case of WINK, how do you sort of ensure sort of the continuous updates of your diagnostic offering and the quality assurance piece?
Yes, so that's kind of a challenge for us as well. And if there's a wire to the internet, it's super easy. You just if there's a complicated case, you can just ask them with the telemedicine and stuff. But about the place that there's no wired, I think we have to update the app, locally. And for example, we already have an algorithm of the auto-diagnostic of cataract with a sensitivity of 99.6% and the specificity of 96%, and that's quite high. So we should improve those values, as much as possible to increase the not to have the misdiagnosis, and keep updating those apps locally. That could be the solution.
And in your case, I mean, how important is it to have a confirmation by an ophthalmologist, or do you require that confirmation?
So there's a few acute cases that should be done, or should be treated soon. For example, the glaucoma, we call the glaucoma attack. That is the aging disease, which cataract is getting more severe, and stop the flow inside of the eyes. That's what we should detect, because if you do not treat the glaucoma attack for, let's say, like one night, the patient lose their sight. So we are focusing on the disease, which is acute disease especially in the eye disease, to not to have those kind of blindness, and I think that is, so the solution is we should gather much more data and enhance the accuracy of the model.
Okay. And Dr. Charrett, I mean, is that in the case of TriCog, is that sort of similar to what Dr. Shimizu was saying in terms of the updates to your solution or new applications that you might be sharing and ensuring the quality assurance?
So I'll answer that in two separate parts, and the first is the update part, and what we have done, Monique, is that we use an ECG machine which is made by GE. So the data that comes from the patient is from an FDA approved device, and these are devices that have been there for years. They're really very reliable. Now the piece there onwards, everything is monitored by the central server. So when you are dealing with a very distributed set of devices, and today we are in about 14 countries, and relying on salespeople to physically go inspect and check the devices is a significant problem. So the way the system has been designed is to be completely um, automated on that aspect, where you check, for instance, is the device plugged into the power system or not, right? Simple problem, which is never a consideration in the developed world. But in the developing world, you have power maybe for 2 to 4 hours a day, but you're expected to run your service 24 hours. So if the battery is running low, for instance, you will immediately get an automated alert that says ensure that your device is plugged in. Now, so we've taken remotely maintaining these devices very, very seriously, because that is the enabler of the service. And if your device is not working well and has not been designed to work well, the rest of the service does not work. Now, because we use AI in the background, and that is a continuous learning process, we have the cardiologist in the loop at all times, and with each ECG reading that comes in, the AI does get better and better. And the advantage of being an entirely cloud first service is the fact that uh, accurate diagnosis, latest diagnosis is actually used worldwide, and learnings from one region get automatically translated to learnings to helping doctors from around the world. So that is a great advantage of being a cloud first service.
Thank you, Dr. Tritt. One criticism sometimes that comes with point of care solutions is that they may be less accurate, and you may require a secondary confirmation. And maybe that's sort of one of sort of the more traditional view of that. And so when if you do a secondary confirmation, in the end it might actually increase the cost rather than lowering the cost. So we've talked a bit about how these solutions are really meant to be more affordable and more accessible. Is still a fair criticism today of point of care? Has point of care really evolved so that you're getting that level of accuracy that you don't need to have that confirmatory test? I'm thinking on the in vitro diagnostic side in a lab, for example. But I think it's a relevant question, for, across the different solutions we're seeing. I don't know if Joaquin and Jose Luis want to answer that question first, and then we can move to the others.
Okay, I think something very important to consider here is in some cases for IVD testing, there's already an algorithm that requires a previous test and a confirmation test. Let's think, for example, in tuberculosis. So for that kind of algorithms, a point of care test is very important, for example, for triage screening of patients who could be in the suspicion of having that disease. So a point of care test in that case, it helps you to increase the number of people that you can detect on the potential of having that disease, and then send these people for confirmation. So that way you are finding those missing cases. So in this case, point of care diagnostics is very important. But there's other kind of diseases where, for example, the accuracy of current point of care tests is enough to actually give a diagnostic. So there are, for example, a test that can give you sensitivities over 97, 98% for certain diseases that were, for example, the same healthcare worker at the moment, at the point, can make the diagnostic. If it's positive, give the treatment and start with the treatment as soon as possible. That way, you increase the possibility of that individual to overcome the disease and have a better quality of life. So current point of care diagnostics are getting into that point where by themselves can have the accuracy of a lab test. However, in some cases, you will still need a confirmation as part of the algorithm, because that's the way the algorithm is right now. That doesn't mean that, for example, in the future, these algorithms evolve to allow, for example, that point of care could be a confirmation test for certain diseases.
Joaquin, would you agree?
Yes, I absolutely agree. I think the point of care test devices are getting more and more accurate and sensitive, even though there are certain chemical limitations compared to some lab tests. But then lab tests, for example, have entirely different problems, because you might be able to collect the sample at the point of care to then send it to a laboratory, but there's confusions about the sample. There's maybe breakdowns in the cold chain. There's other problems with handling the sample. So the accuracy is severely reduced, even though the actual technology might be a bit more accurate in the laboratory. And then also when we're talking about a context where there's few qualified laboratories, where there's long distances to specialists in laboratories, it becomes a very theoretical question whether there's slightly better accuracy in the laboratory, because you have no access to the laboratory. And the laboratory is per se more expensive. And also, if you don't think about an individual diagnosis, but you think about a population, because the WHO doesn't just talk about diagnostics, they speak about screening and surveillance, because you need to keep track of what's going on. And you need to, once you have established, an overview through screening of what's going on in your area, you also want to keep tracking it. You do want to do the surveillance bit. And for that, you need the connectivity to the point of care. And that can only be done through point of care technologies. And if you take, for example, the COVID-19 or other outbreaks like Ebola, one of the key things is that you quickly identify correctly where there is outbreaks, where there is, expansions of the disease, and that you can only do again at the point of care. And earlier we've had like 2 weeks notice period between the identification of patient 0 and the reaction starting. With our technologies that we're presenting here, it's in real time. So you don't have that lag, which then actually causes most of the cost that you have. Because if you only look at the cost of the procedure, you're missing out on a huge bit of the actual problem.
Mihir, what about in the case of the eye breast exam? I mean, what does sort of a secondary confirmation look like, or what's needed in the case of the eye breast exam?
Sure. See, the issue with breast cancer in the developing world is that majority of the cases present at a late stage. So that's the biggest issue. There's access to treatment available, but women are presenting at a late stage because there is no access to widespread triaging or screening. And that's the need that we are solving for. So in case of our product and our target market, eye breast exam is being provided to healthy asymptomatic women, because you're triaging that population to figuring out who has a health condition that needs to go forward. So typically we see about 4 to 5% positivity rate in a screening triaging environment from the healthy population. The 95% go home. And what you want to make sure is that the ones you're sending home, you're sending them home with a very high negative predictive value, with a very high confidence level. But at the same time, the ones you're advancing, you want to be, you don't want to have high false alarm, false positive rate. And yes, there is, eye breast exam is not a definitive test. It's not a diagnosis of breast cancer. That only happens with a biopsy or fine needle aspiration cytology. So we help define the funnel really quickly and narrow that funnel from a wide population. That's the value we provide. And then there is a second step diagnostic required, but on a very small population and in a targeted fashion, because we identify the area in which a diagnostic breast ultrasound can be performed. So this is parlaying and creating, it's all about creating a funnel that is, as a system, more effective, affordable, and accessible than just beating out on sensitivity and specificity. Because again, as Hakeem said, most of the tools are not available. So it's a theoretical question, because if you could do mammogram for every woman in the world, then we wouldn't exist. But that's not a possibility in the near future.
Even with mammogram, you don't always find everything. So.
And those are not perfect either. Yeah.
Absolutely. So, and Dr. Shimizu, and what about in the case of Wink? Is it definitive? The provider uses your service, they have a definitive answer, or what does secondary step look like?
Yes, well, I think that the situation of ophthalmology is similar to the breast cancer, that if the patients come to the ophthalmology clinic, they're like nearly blind because of the severe cataract, and if they done the surgery, they won't be it's not like survive, but they could lose the vision with that. So I think the problem is, number one, is that we have to expand more knowledge to the patient, that the eyes could be treatable. For example, the cataract, if you're gonna get the surgeries, the patient's gonna get back their vision and get back where they were. So we have to educate no, it's not patient, but the population, that the eye is a treatable. And the second thing is that so that's, I think, the one of the issue that we have. And the second thing is that if the patients get diagnosed, there is no treatment method, because our device is only a diagnostic tool. So we have to make for the road or some kind of traffic to connect our device plus the treatment facilities. So one time we had done the testing in Malawi is we had a pilot project with the NGO called BICO, which is doing the cataract surgeries and helping the patients in the Malawi, and they can do the surgery. So for example, our device can screen the patient, and if we can send the patient to the those facilities that they can have a surgeries. I think our goal that to prevent blindness in 5 years, 50% of blindness in 5 years could be possible.
Great. Dr. Chera, just giving you a chance to come on this, and I think Mihir was mentioning about the trade-off between sensitivity and specificity, and in your case, there's also a trade-off with speed. So how do you consider that in the case of TriCog?
So I think it's one of the most important questions that you pose to all of us. Take Kenya, for example. There are over 50 million people. There are 150 dedicated cardiologists, right, who have to take care of the health of the whole nation. We need to make sure that a heart attack is diagnosed within 6 minutes and treatment started anywhere in the country. And to do so, and to do so, you need to overcome the limitations of every piece of technology, as sensitivity, specificity, what all of us love to speak about. But when you have to make a life and death decision on a patient, for instance, here's a person with a heart attack, and you need to make sure that within either the golden hour or 30 minutes, you inject a drug to save his life. Making sure that you build a system that delivers that diagnosis at the point of care within minutes makes a difference between life and death. In our case, we always have a doctor in the loop to verify that diagnosis for medical legal aspects. But not far away from now, this whole thing could be entirely automated thanks to the advances of technology as we speak.
That's great. And I think our next session is actually going to go in more depth about AI. So I agree with you. It's an area we're seeing a lot more applications in healthcare, and it's pretty amazing. So we're approaching the end of our hour. So I just wanted to wrap up really quickly and say, well, first to say thank you to all of you for your participation. And I hope that this is a successful event for all of you. Apologies. Now, thank you for educating us on point of care solutions, about the benefits of these solutions, particularly in the emerging market and in African context, about the possibility to locate these in remote settings where similar options are really not available. We talked about the speed of diagnosis, but at the same time, the importance of the accuracy and these really being affordable. So I think there's really some incredible solutions here. It's really, I think a lot of these are really relevant, and you can see how these applications are going to be really incredibly important, going forward. So thank you again, to all of you for being on this panel. I hope that you have some successful conversations with some of the providers here. And thank you to our audience for joining us. I hope you learned something, as I did, from the panel, and I hope you all enjoy the rest of the event. So thank you so much.
Thanks, Monique.
Thanks a lot.
Thank you very much.
Thank you. Good to be with you.